Hello friends, welcome to Pathology Basics. Till now you have heard only my voice. This is for the first time I am introducing a video of mine teaching. Anemias is the topic for today, and anemias is a very important topic not only from pathology subject point of view, but it is important throughout MBBS in various subjects. It's a very common disorder seen in Indian conditions. So let's start with anemias. What is anemia? Anemia has been defined in different ways. It is defined. There are various definitions given in different textbooks. One of the most common definitions is it is reduction of total circulating red cell mass below the normal limits. Red cell mass that circulates in the blood, when it is less than the normal limits, we call it anemia. Another common definition is it is the reduction in oxygen carrying capacity of the blood, right? So when there is reduction in oxygen carrying capacity, may be due to either less number of red blood cells, or we can say less red cell mass, or the red cell mass is normal but its oxygen carrying capacity is low due to various other causes, we call it as anemia. So anemia, morphologically, when we look at the blood film under the microscope, we see three main types of red blood cells. The red blood cells can either be microcytic, normocytic, or macrocytic, and this is defined on the basis of the size, or we can say the volume, or the mean corpuscular volume of the red blood cell. If it is less than 80 femtoliter, we call it as microcytic anemia. You can see that the size of the cell is less than normal on the peripheral smear. Normocytic anemia, when the size of the cell is normal, and macrocytic anemia, when size of the cell is larger than normal. Definition wise, if we see what is the number below which we call as anemia, again this differs from country to country, region to region, but in males, if hemoglobin is less than 13 and females less than 12, we call it as anemia. Again, if we see further division of microcytic anemia, the most common causes of microcytic anemia are iron deficiency anemia, which we'll be covering first. Thalassemia is another cause of microcytic anemia, and anemia of chronic diseases. All these we'll study in detail later on, so I'm just referring to the names right now. Normocytic anemia is seen in acute blood loss, chronic diseases because of hemolysis, because of renal insufficiency, and in sickle cell disease. Of course, in sickle cell disease, the typical feature is sickling of the RBCs. Macrocytic anemia is again divided into various types, but the most common cause of macrocytic anemia is vitamin B12 and folate deficiency. Apart from that, alcoholism, bone marrow disorders, hypothyroidism, and liver diseases. These are the causes of macrocytic anemia. So this is the very common classification used based on the size of the RBCs for anemia. This is the classification of anemia given in Robin's textbook of pathology, which we follow very commonly. The first cause of anemia, etiologic. This is called as the etiologic classification of anemia. First, anemia is due to decreased red cell production. Due to blood loss is another cause. Increased red cell destruction leads to anemia. So the anemia may be due to decreased production, increased destruction, or due to blood loss. What are the causes of decreased red cell production? Decreased red cell production is due to most commonly nutritional deficiencies like iron and folate and B12. It may be due to genetic defects such as thalassemia. It may be due to renal failure because there is decreased erythropoietin production. It may be immune mediated such as aplastic anemia, and so on. We'll discuss each of them in detail as we come to them. Blood loss anemia, it may be due to trauma, or there may be gastrointestinal or other blood loss in the body. Increased red cell destruction, mainly that is hemolytic anemias. Hemolytic anemias may be due to spherocytosis or elliptocytosis or G6PD deficiency. Again, increased destruction is seen in thalassemias and sickle cell disorders, paroxysmal nocturnal hemoglobinuria, and hemolytic disease of the newborn. We'll see all of them. Let's start today with anemias due to diminished erythropoiesis, that is, anemias due to decreased RBC production. Now, the most common cause is iron deficiency anemia, and we'll be referring to that mainly today. Iron deficiency anemia, the prevalence of iron deficiency anemia is very high in developing countries. It is seen in toddlers, adolescent girls, and women of childbearing age. There are various causes for that because of lack of nutrition. Of course, people do not get enough nutrition, do not get enough iron. Adolescent girls because of menstruation. Women of childbearing age due to repeated childbirths with very less interval between two children. Now, normal Western diet, it contains 10 to 20 milligram of iron because ingestion of animal products is more. Heme is the form of iron in animal products. Remainder of iron is inorganic iron found in vegetables, but that is in lesser quantities. Therefore, in developing countries, especially those who have a vegetarian diet, supplementation with iron is very important, especially in adolescent girls, menstruating girls. Before we understand iron deficiency anemia, we need to understand iron metabolism. Now, to start with, iron, around 1 milligram of iron is required from the diet every day. Also, whatever iron is ingested, out of that only 10 to 15% of the iron is absorbed, right? So the amount of iron that should be intaken, if we say only 1% is absorbed, so around 10 milligram of iron is required for men and 20 milligram of iron is required for women. Out of that, only 1 milligram will be absorbed. Also, as we already saw, heme iron is much more absorbable than inorganic iron. Absorption of inorganic iron, it is enhanced by ascorbic acid, citric acid, and amino acids, and it is inhibited by tannates which are found in tea, also inhibited by carbonates, oxalates, and phosphates. Therefore, when we are supplementing iron, it is very important that iron supplementation should not be given along with tea, carbonates, oxalates, and phosphates. In case of iron, if we talk about distribution in the body, 80% of the iron is functional and is found in enzymes and as a part of hemoglobin and myoglobin. 20% is not functional, it is storage, and it is stored in the liver cells in the form of ferritin. When ferritin stores are full, then it is stored in the form of hemosiderin in various macrophages. So this is how iron is distributed in the body. Important to note that healthy young females have smaller stores of iron than males because of blood loss during menstruation. Therefore, the storage is already low, and therefore even mild forms of bleeding can produce iron deficiency. Therefore, they need supplementation. Again, as I told you, most of the storage is in the form of ferritin. Normally, hemosiderin is found in macrophages in the bone marrow, spleen, and liver. Okay, only when ferritin stores are replete, then iron gets started stored in the form of hemosiderin. Now, how is the iron balance maintained in the body? If we see, iron is absorbed in the intestine. Then after absorption, it travels in association with transferrin. Transferrin carries it to the liver, and whenever body requires, liver releases it back into the plasma. Some of the transferrin iron is transferred to the marrow, macrophages, erythroid precursors. Then the iron enters the circulating erythrocytes, and when the erythrocytes die at the end of 120 days, it is released back into the plasma. Some amount of iron is also given to the skin, gut, and the endometrium, and then as their cells die, again they shed. Right? Now, the iron balance as such is maintained only with the help of absorption. right? So the absorption of iron in the gut is regulated. That is the only way the iron balance is maintained. That is to say, when the body is replete with iron, then the absorption of iron from the gut is decreased, and when the body needs iron, more amount of iron will be absorbed. So that is the only way that the iron balance is maintained. There is no regulated pathway for iron excretion. 1 to 2 milligram is lost each day through mucosal and skin epithelial cells, right? And as I told you, as the body's iron stores increases, absorption falls, and vice versa. So this is how absorption happens. There is heme iron in the food, or there is non-heme iron. If heme iron is there, it is directly transported inside the liver cells. If it is non-heme iron, it takes the help of duodenal cytochrome B or ferric reductase enzyme, which converts ferric iron to ferrous iron. Ferrous iron is then absorbed. It is then converted into mucosal ferritin and stored. Whenever required, this ferritin can be converted back, right? The heme iron can be transported through ferroportin and DMT1. Again, it is reduced. Ferrous iron is converted to ferric iron with the help of hephaestin and ceruloplasmin oxidation. It joins with transferrin, and it is transported through different parts of the body, like it is transported to erythroid marrow. It can be taken back into the liver. The hepcidin is an important molecule and plays a very important role in iron metabolism. I'll tell you how. Iron absorption is regulated by hepcidin, alright. It is released by liver in response to increased iron levels. So when the body is replete with iron, higher hepcidin level inhibits its absorption from the blood into the liver. So what that means, when the body is replete with iron, it causes increased storage of iron inside the liver cells, as well as it stores the iron in the macro. Hepcidin, as you might have realized by now, is associated with various disorders of iron metabolism. Anemia of chronic disease is caused by inflammatory mediators that cause increased hepcidin production. We'll come to anemia of chronic disease in detail. Mutations that disable TMPRSS6, it is a serine protease. The patients have high hepcidin levels. So you imagine, if the patient has higher hepcidin levels, even if the body iron stores are low, it will reduce iron absorption and cause anemia. Hemochromatosis is a condition in which hepcidin activity is inappropriately low, right? And secondary hemochromatosis, it is seen in diseases with ineffective erythropoiesis. Ineffective erythropoiesis suppresses hepatic hepcidin production even when iron stores are high. These are all the diseases. We'll see them in detail later on. So now coming to etiology of iron deficiency anemia. Iron deficiency anemia happens because of a dietary lack. It may happen because of impaired absorption, or sometimes there is increased requirement of iron, or sometimes there is chronic blood loss. So all these can lead to iron deficiency anemia. Dietary lack is seen in developing and underdeveloped countries, in infants, because the milk contains very less amount of iron. So if you don't supplement, sometimes they have high risk of iron deficiency. Menstruating females, they also need supplementation. Impaired absorption, as we saw that iron absorption is enhanced by ascorbic and citric acids, amino acids and sugars. It is inhibited by tannates, carbonates, oxalates and phosphates. Malabsorption conditions such as PRU and diarrhea, they can cause iron deficiency anemia, and gastrectomies can cause iron deficiency anemia. Increased requirement can be seen in infants because they are growing, in adolescents, as well as premenopausal women. Also in pregnancy, increased requirement of iron can be seen. Chronic blood loss because of external hemorrhage or bleeding into the GIT or urinary tract, there can be increased requirement of iron. So then how does a peripheral smear look like for a case of iron deficiency anemia. The cells are typically microcytic and hypochromic. What does that mean? The cells are lesser than normal in size. How do you compare, how do you know on peripheral smear what is the normal size of RBC? So the size of RBC normally is the same as size of nucleus of a lymphocyte. So compare the size of the RBC with size of the nucleus of a lymphocyte. If it is of the same size, it is normocytic. If it is lesser, it is microcytic. If it is more, it is macrocytic. So if you can observe, these cells are smaller than that, so these are microcytic. Normally at the center of each RBC there is only 1/3 pallor. This looks normal to me, but this cell has more pallor, therefore it is hypochromic, right? Also we can see poikilocytosis. Poikilocytosis means there is different shapes. As you can see over here, this appears elongated. We call it as an elliptocyte, or we can also call it as a pencil cell. So there is poikilocytosis as well on the peripheral smear. If you see the bone marrow, the iron storage in the bone marrow is reduced. So this is a Prussian blue stain which stains the iron in the macrophages. This is the normal bone marrow, and this is marrow in case of iron deficiency anemia. Clinical features, of course, most of the features are there of any typical anemia. There is fatigue, loss of energy, of course there is tachycardia, and particularly when you exercise there is tachycardia. There is shortness of breath, difficulty concentrating, pale skin, insomnia, dizziness. All these typical signs of anemia will be seen in iron deficiency anemia. Clinical features, others, we can see that there may also be signs related to depletion of the enzymes which contain iron. Typically koilonychia, alopecia, atrophic glossitis, and intestinal malabsorption. All these are there. Features related to intestinal malabsorption are there. Depletion of iron from the central nervous system leads to a typical sign called as pica, and it is seen only in children. What does it do? It makes the children eat non-food stuff such as clay or flour, or sometimes they even start moving their limbs in sleep. All these are signs of low iron in the central nervous system. It is called pica. This is koilonychia. You can see the change in shape of the nails. This is atrophic glossitis. You can, in case of severe iron deficiency anemia, and especially in a condition called as Plummer-Vinson syndrome, there is definitely hypochromic microcytic anemia, there is atrophic glossitis, and the third feature of Plummer-Vinson syndrome is esophageal webs. These kind of webs are seen in Plummer-Vinson syndrome. It is a clinical feature of iron deficiency type of anemia. How do you diagnose iron deficiency anemia? Iron deficiency anemia, of course, if you do a complete blood count, in that you will see that the hemoglobin and the hematocrit are depressed. Serum iron and ferritin levels, when you measure, of course, they will be low. The iron binding capacity, it will be high because there is less storage of iron. Transferrin levels will also be elevated, but saturation with iron will be less than 15%. Reduced iron stores will inhibit hepcidin synthesis, so if you measure serum hepcidin levels, they will fall. Retic count, of course, will be low, but when you start supplementing iron, then it leads to a reticulocytosis in about 5 to 7 days, and this is the diagnostic feature of iron deficiency anemia. So we covered the first part of anemias due to diminished erythropoiesis, that was iron deficiency anemia. So this was the first part of my videos on anemias. We covered iron deficiency anemia. I also introduced the topic, classified anemias into different types. In the next video, which will be uploaded very soon in 1 or 2 days, I'll be covering megaloblastic anemia. Please everyone, be safe at home, be safe during this time of pandemic. These are very testing times, but as we have overcome everything till now, this also we will overcome very soon. uh, till then, keep tuned into Pathology Basics, keep revising your basic fundas, uh, and we hope to get back to normalcy very soon. So thank you very much. If you liked my videos, please subscribe to my channel, like and share these videos. Thanks a lot.